Well, I would like to thank again the organizing committee. It's a pleasure to be here with all of you. It's my first time here and I'm really enjoying the Congress. I think it's a really good Congress. I'm a bit afraid because it's the first time that I have 4 chairmen in my speech. So, well, let's start. The topic of this lecture is perioperative optimization of mechanical ventilation evidence. Well, the evidence of the protective mechanical ventilation in healthy surgery patients, well, has no more than 5 to 7 years, so it's a quite new evidence, and this is because, well, we are aware of that protective or that mechanical ventilation could be a problem in the surgery patients, healthy patients, with really new data coming from, for example, I think this is one of the first studies coming from our Spanish group, showing that the incidence of postoperative pulmonary complications in healthy patients, at least with healthy lungs, was really high in cardiac surgery. Close to 40% of the patients develop postoperative pulmonary complications, thoracic surgeries with more than 30% of the patients, or even abdominal surgery patients, selected patients in selected surgeries with incidence higher than 20-25%, and in some studies close to 40%. So with this data, the anesthesiologists start to realize that we should improve our mechanical ventilation strategy in the OR, because this is not only a problem to the patients, because an increase in morbidity, probably an increase in the ICU and hospital length of stay, but also it's a problem for the healthcare systems, because those patients who develop postoperative pulmonary complications are really expensive patients. So we should try to improve our management, trying to help our healthcare systems, because at least in Spain we have some economical problems and we should help as much as possible to the healthcare system. Well, there are some factors related to these postoperative pulmonary complications that we cannot modify as an anesthesiologist. Those factors related to the patients or even to the surgery, but we can modify those factors which are related to the surgery or even in the postoperative period. And not only ventilation, which is the topic of the lecture, but also with the fluid management, with the anesthesia, or even in the postoperative period with the pain control, or as was said in the previous lecture, with the use of reversal neuromuscular blockers. But we are going to talk about ventilation in this lecture. So which one is the evidence of the protective mechanical ventilation? As I said, it's quite new, and what we should take into account is which ones are the different mechanisms that injure the lung. So how can we protect the lung from our mechanical ventilatory strategy? So we know that we have different mechanisms. The main ones are the atelic trauma. So we should prevent this atelic trauma with the PEEP setting. We should set a level of PEEP in our patients with or without recruitment maneuvers. We are going to see that. We have to prevent over-distension with the use of low tidal volumes, but also with the use of recruitment maneuvers and PEEP, because with this strategy we can restore the functional lung, so we will ventilate more lung for the same tidal volume, and this will decrease pressures and we will decrease the risk of over-distension. And we should think, since the last 2 years, about the driving pressure. The driving pressure that we usually do not set. The driving pressure is a consequence of our strategy, but what we know now is that the driving pressure monitors the functional lung volume and seems that is the single most important independent predictor factor related with postoperative pulmonary complications, and we start having now many data showing that each centimeters of water of increase of driving pressure increases the risk of developing postoperative pulmonary complications. So our protective strategy also should be aimed to reduce the driving pressure. So as I said, the evidence is quite new. This is one of the most recent meta-analyses of 2015 published in Anesthesiology. And let's make a look to which one is the evidence of the different parameters that we usually adjust in our healthy patients. Let's talk about the tidal volume. There are only 3 studies comparing in healthy patients undergoing surgery different tidal volumes with the outcome of postoperative pulmonary complications. And those 3 studies just including more or less 400 patients. And the evidence is a trend toward benefit of the use of low tidal volume, but it is not statistically significant. So it seems that the use of low tidal volume could be protective, but nowadays we do not have a clear, or at least significant evidence that this strategy alone protects the lungs. However, we have another meta-analysis published in the same journal, almost at the same time, telling us, well, the contrary, that there was a relationship between the tidal volume and the risk of developing postoperative pulmonary complications. Well, the thing is that this meta-analysis include 15 randomized controlled trials, almost 2,000 patients. The problem is that most of those trials, they did not just compare the tidal volume, they compare a bundle of measures. Yes, low tidal volume recruitment maneuvers and PEEP versus high tidal volume, no recruitment maneuvers, no PEEP. But with a complex statistical analysis, they found that, well, the tidal volume was related to postoperative pulmonary complications. So if we reduce our tidal volume, we will reduce the risk of developing postoperative pulmonary complications. Seems that, well, anesthesiologists are doing the things well. This is Las Vegas study, a European study of including patients for more than 29 countries. This was published several weeks ago. And, well, seems that the tidal volume that anesthesiologists are using in healthy patients in surgery is close to 8 milliliters per kilogram of predicted body weight. But we still ventilating some significant number of patients with tidal volumes higher than 8 ml kilogram. That means that we still ventilated some patients with a non-protective tidal volume. They also found in this cohort of almost 10,000 patients a relationship between the tidal volume and the risk of developing postoperative pulmonary complication. That means that if we increase tidal volume, we have a higher risk of developing postoperative pulmonary complications. How about PEEP? Well, this meta-analysis, same meta-analysis that I present you, 2015, there are no new studies regarding this topic, so this is the correct meta-analysis, tell us that PEEP do not affect postoperative pulmonary complications. Just one study, the Provilo study, I will talk about this study, including more than 900 patients, and they just compare an open lung approach, recruitment maneuver plus high level of PEEP versus low level of PEEP without recruitment maneuvers, and they didn't find differences in postoperative pulmonary complications. But if we take a look to the other meta-analysis, which, as I said, include 15 randomized controlled trials and more than 2,000 patients with this complex statistical analysis, they found a relationship between the PEEP level and the postoperative pulmonary complications. However, in my opinion, those results that they present, that you can see in the graph, it's a big problem for us as anesthesiologists. They show that if we use levels of PEEP between 2 and 9 centimeters of water, between 2 and 9, we are increasing the risk of postoperative pulmonary complications. So if we believe in these results, we should not use PEEP, or we should use PEEP at PEEP level higher than 10, higher than 9. This is what this meta-analysis is telling to us. And as I said, this is a big problem. Take a look to the Las Vegas study, 29 countries, more than or close to 10,000 patients, and the PEEP level more frequently used is 5. But if we take a look to the other data on your right, the LATA study coming from the United States, I think it was 69,000 patients. The higher PEEP, the higher, most frequently value of PEEP use again was 5. This is the level that we normally use, between 5 to 10 is the most frequently PEEP values that we use in the ward. But if we believe on the results of the meta-analysis, those PEEP values are injuring or are increasing the risk of postoperative pulmonary complications. However, this registered study published by the group of LATA, almost 70,000 patients, they found that the more protective PEEP level was around 5 centimeters of water. So why this meta-analysis found these results? Because it's based mostly in the results of the ProVilo study. The ProVilo study is a European study from the Provenet group of the ESA, and they compared two different strategies, an open lung approach and a conventional strategy, or what they call conventional strategy. The open lung approach, both groups were ventilated with a low tidal volume, break the body weight around 7 ml/kg. The higher PEEP group was ventilated with 12 centimeters of water. We're talking about healthy patients with healthy lung, non-obese patients under laparotomy. 12 centimeters of water seems too high. And the control group was 2 centimeters of water. And this was a negative study, which means that they did not find differences between the higher PEEP group and the low PEEP group, which means that could be high between 2, as good or as bad. In my opinion, 12 is as bad as 2, because 12 is too high for many patients, and they found this explanation in a post-hoc analysis that they performed, where they realized that almost 40% of their patients in the higher PEEP group, when they increased PEEP from 5 to 12, driving pressure was higher, which means that compliance was lower, which means that 12 of PEEP was over-distending the lung in those patients. So is good 12? No, it is not. Is good 2? No, it is not. Probably someplace between 2 and 12 is the good level of PEEP. This study is the last one that has been published in healthy patients undergoing surgery, in cardiac surgery patient from the group of Amato, the Brazilian group, published in JAMA a couple of months ago. And they compare again an open lung strategy versus a conventional strategy. Well, in the title they call moderate alveolar recruitment maneuver. It was not perform a recruitment maneuver in this group. They just apply a CPAP of 20 during 30 seconds. A CPAP of 20 centimeters of water does not recruit the lung. And they thereafter set a level of PEEP of 8 centimeters of water in this moderate alveolar recruitment group, and in the other group, the protective group, the open lung group, or the intensive alveolar recruitment group, they perform a standard recruitment maneuver, and they set 13 centimeters of water of PEEP. So they compare an open lung approach versus a conventional approach or non-open lung approach, and they found that this open lung approach in cardiac surgery patients decreased postoperative pulmonary complications. So now we have two trials comparing just a PEEP approach, an abdominal surgery patient negative study, and cardiac surgery patients positive study. But this study has not been included in any of the meta-analyses that I present you. What we know is that when we compare a bundle of measures inside the protective strategy, which means low tidal volume recruitment maneuvers and PEEP, compared to high tidal volumes, non-recruitment and no PEEP, has a protective effect. So this low tidal volume open lung approach decreases the risk of postoperative pulmonary complications. There are some trials. I'm going to show you the most important one coming from the French group from Foutier, published in the New England Journal in 2013, and they compared this protective group, low tidal volume, 6 ml kilogram, or between 6 and 7 ml kilogram, recruitment maneuvers, a CPAP of 13 during 13 seconds, and they applied a PEEP of 6 centimeters of water, and in the conventional group, they used a high tidal volume, 11 ml kilogram. This is a non-protective control group. They did not recruit the lungs, and they did not use PEEP. Obviously, they found significant differences in the primary outcome, which was an endpoint composite of pulmonary and systemic complications. So with this bundle of protective strategy of low tidal volume versus plus open lung strategy, they found positive results. Our proposal is this one. We just end this trial, including more than 1,000 patients, abdominal surgery patients. Nowadays is the highest trial that has been performed. We propose a perioperative strategy, not only including the mechanical ventilation during the intraoperative period, but also preventing atelectasis during the induction and treating or preventing atelectasis during the immediate postoperative period, because we know that those patients, high-risk patients, develop atelectasis after the extubation. So this is the trial that we propose, with a low level of PEEP during surgery, with a recruitment maneuver, and with an individualized PEEP to the best respiratory system compliance. This is one of the most important things of our trial, because we do not use a standard level of PEEP for every patient. We use an individualized PEEP because we think that different patients need different PEEP values. It is not the same a patient with a BMI of 20 in a laparotomy that a patient, for example, with a BMI of 30, 34, 35 under laparoscopy. It is not the same. Probably the first patient will need a low level of PEEP, the second patient will need a high level of PEEP. So this is our proposal. We compare 4 different groups, from the most individualized group on your left to the standard group. Other thing that differentiates our study with the others is that our control group was a protective group. We did not use high tidal volume, we used low tidal volume, and we did not use a group without PEEP. We used a protective 5 centimeters of water of PEEP in our control group, because the evidence shows us that this is the level of PEEP that we at least should use in our patients, that healthy patients under mechanical ventilation. So I cannot show you the results because the paper is under review. I'm just going to show you one of our secondary outcomes, that is pulmonary complications. This is the Kaplan-Meier graph. You can see here the color of the different groups, and you can see here how postoperative pulmonary complications appear during the postoperative period. But you can see the difference between the individualized groups when compared to the most standard group, and hopefully we will publish the results during the next week, so you can read the paper hopefully during the next month, but well, it is not accepted yet. It's in the review, so we will see. And just to end, quite simple conclusions. We should be aware that the incidence of post-operative pulmonary complications in high risk or moderate to high risk patients is really high, could be as high as 40%. And well, we should not forget that lung protective ventilation in healthy patients during surgery is quite easy to perform, which should maintain a low tidal volume, below 8 ml kilogram predicted body weight, no real body weight. We should recruit our lungs, because we know that atelectasis appeared in almost all patients during the induction and during the first minutes of the mechanical ventilation, and we should set an adequate level of PEEP. In our opinion, we should individualize the level of PEEP, but at least you should use 5 centimeters of water in most of your patients. Thank you very much.